All right. No more distractions, so you don't have to sit on those uncomfortable chairs. We'll buzz through that as expeditiously as possible. Moving on. So, yeah, I figured we left off roughly around here because I mentioned commenting on PID. There's a little bit more of a nugget about that afterwards as well, because I think in this chapter they do talk a little bit about STDs and things. I'm not going to go into it because it's not on the exam per se, as I recall. The uterus itself. And again, that's why I pointed out to you anatomically, it normally is inclined forward in an anterior direction. That's typically where it is. When it inclines backwards, it's usually in anticipation or during intercourse. I don't think that's really a big deal. Its function is pretty obvious when you talk about receive, retain, and nourish the fertilized egg. Where it all occurs is in the body. The dome-shaped portion is called the fundus, same name we give to the dome of the stomach. The isthmus is it gets to narrow on its way out. The cervix is technically the neck-like opening in between that and the vagina, and then you have an internal and external opening, not a big deal. Glands are all about mucus at that particular point. This is, if nothing else, depending on what your philosophy is about vaccines, and with, right now with only you ladies in the class, uh, my guess is probably some of you were immunized, and maybe some of you were not. I don't know. Okay, with the Gardasil, that was a relatively new finding, but the numbers are staggering for cervical cancer. I am troubled by the overabundance of vaccines in many instances, but this is just so extraordinarily. I mean, if you're looking at these numbers, again, it's about 8 years ago, or so. When you're looking at a quarter of a million women worldwide dying of a disease that theoretically, if not preventable, at least is you can prevent some part of it is of significance. So, and the window that they immunize, if you did not know, is roughly between 11 and 12 and maybe early 20s. However, the recommendations changed. A good friend of my sister's, because I asked him about it, he's deceased relatively recently now, uh, was a very, very well-known OB-GYN in Rochester, New York area. And I asked him about that, and in all his experience, he'd never had an adverse reaction with it. I don't know if that's true or not. I'm sure it's true in his experience, but I don't know what it is statistically. So pap smears, whatever the recommendations are, and they will occasionally change with regard to those. That's really, it demonstrates the abnormal cytology or irregular cytology. And typically, uh, you may, as your lives continue, experience them saying there's some evidence of dysplasia. Dysplasia means it doesn't appear exactly normal. That's typically, we're going to do it again in a couple of months. See what brought that up. Metaplasia means beyond, means that there's a significant change and we're concerned, and the next step is to biopsy. And anaplasia is bad because when something is anaplastic, it's irregular figures mitotically. So that's almost always associated with cancer. And I think the tragedy is that there are, uh, it's what I used to call ostrich syndrome. They would bury their head in the sand. And I've always felt that women are much less likely to do that because they have babies. And they're much more concerned about their reproductive health, but not everyone, to be fair. This is not that terribly important with the ligaments and all that stuff. Don't care. Pouches, don't care. Illustration you've seen a couple of times. Illustration you've seen. Prolapse, interesting, and it's something that typically occurs much more with aging and with at least multiple pregnancies, if not childbirths. Okay, so whether it was spontaneously aborted or intentionally aborted, again, without getting into a discussion of what your feelings are about that, it is impactful. So my mom included, although you were only the two of us, ended up basically the uterus kind of was unsupported, puts a lot of pressure. She had a procedure to repair that many years ago, and I mean, I would say for her, a difficult recovery for a lady who didn't have a lot of operations. My mother-in-law had one done here at McGee when she was in her 80s. They have a whole unit. If you end up going to McGee or being treated there, or know somebody who works there, called a pelvic floor unit, because it's all soft tissue. And I mean, you really have to know what you're doing to be able to, so it's a consistent problem, repairing these diaphragmatic areas. The uterus itself, the outer layer is an outer layer covered in peritoneum. The endometrium is critical because of the changes you'll see shortly. This is all a giant amount of smooth muscle. The myometrium is basically a big muscular sac, just like the bladder is a big muscular sac, but it has other roles. This is the key player in the endometrium. You have two layers. One's called the basalis, which is always there, and forms the new functionalis after menstruation. It doesn't respond to the hormonal changes, whereas the functionalis is all about the hormonal changes, and that's what's shed. As the hormones are utilized, at first it forms, then it enlarges, then it adapts in anticipation of implantation with fertilization. And if that does not occur within 10 days of ovulation, then it sheds in what we call menstruation, which starts the next cycle. This is what it looks like microscopically. Those large areas are glands. That tells you how mature it is, the amount of, quote, glandular tissue. You can see it's filled with material. This below it in the somewhat darker area is the basal layer, or stratum basalis. That's always there. So they appear differently, is the way I would describe it. The critical piece are the arterial supply. Most of the supply for the uterus, even though there may be some tiny amount offshoots of the gonadal artery or ovarian arteries, are off the internal iliacs. They arch over the myometrium, just like we saw arching in the kidney, and then they radiate, meaning they go out straight and branch into the basalis. And at that point, they begin to spiral. That's the critical piece. Spiral arteries like a corkscrew. And when the corpus luteum, what's left after the egg is ovulated, in the absence of implantation, begins to deteriorate and no longer producing progesterone, those arteries go into a spasm. I said it before, when you have an artery that's blocked, whether it's a big tourniquet or whether it's a spasm induced by chemical changes, it builds up a pressure head behind it. When it's blocked, the layers have no blood supply. They separate. The tissue deteriorates where they're adherent to one another. And then when that pressure is released, the pressure head the blood is exposed, it basically induces it to slough. All the time. I mean, I have a ton of experience and I did a ton of research with extremity tourniquets, wrote papers on it in one of my areas of expertise. I have a limited amount of expertise in something. Not a lot. Schematic drawing to give you the size of these glands that produce a lot of the materials that are going to be very important in nutrition for the developing embryo and then fetus. Straight arteries radiating, then spiraling at the start. And so this is sort of that space. It's almost, the analogy would be like a blister. If you want to think of a blister is a fluid that forms in between the dermal and epidermal junctions. Okay, and the piece comes off when there's a sufficient amount of pressure, trauma, or it ages. Vagina, 3 to 4 inches, birth canal, copulatory organ. You know where it's located. Urethra runs parallel and anterior to it. Fibroelastic in nature, stratified squamous. And again, the idea of the stratified squamous is because now you have exposure to the outside. We always make the transition to stratified tissue because of that kind of exposure or anything that could be placed in there or come into contact with it, etc. Okay, acidic in the adult, that's the key issue. In the adolescent and in the postmenopausal, it reverts back to alkaline, with mucus being the barrier. In the menstruating female, during those childbearing potential years, it's all about the acidity. We do chapter and verse on this with lactobacillus. Lactobacillus is the most important of the bacteria. It's easily killed. That's why broad spectrum antibiotics. The hymen ruptures typically with the first intercourse, etc. This is the typical vulvar view. And again, analogous to when we looked at the perineum view in the male, except anatomically obviously different, except when you remove the outer structures that are there. You have the clitoris with the glands or prepuce. You have the mons, which is fat and hair covered. The labia majoris have hair, the labia minoris don't. This is one where the hymen is already ruptured. You can see the anterior, but you see the proximity of these structures, not so in the male, and that accounts for a lot of potential sources of infection in both the urinary tract and then the vaginal tract. And and they're not all necessarily related to hygiene. We have aging, we have incontinence, we have a variety of other factors that play a role into that. This is sort of, and I told the same thing in my other class. We grew up in the now no longer, but pre-Roe v. Wade world, okay, where abortions were always illegal rather than state to state. This is now basically the interpretation of the law, again, without getting into the legal aspect of the discussion. Effectively, what happened, people would, when a girl got, quote, in trouble, a lot of times people were trying to help her, whether they were trying to help her with some type of medications or backroom procedures, and a lot of women were maimed, damaged completely, if not died, from not understanding the anatomy, because remember, it goes forward. Okay, and so the whole lay of the land, okay, using something, a surgical instrument, or in some cases a coat hanger, where bent would potentially cause irreparable harm. They weren't sterile, peritonitis, gangrenous uteruses, if you can only imagine how terrible that would be. Permanent, if they survived, permanently unable to have children. That was kind of the trigger for the Roe v. Wade concept, which was decided by the Supreme Court in '74. And then obviously recently we've had, I don't know if overturning is the right word, but modifying it maybe is a better word. I'm not a legal expert whatsoever. So that's sort of the precursor to it. The external genitalia, you can look through these, there's nothing. And again, the counterpart, the labia majora, the counterpart of the scrotum. Okay, just noteworthy with regard to that. Glands similar to the bulbourethral glands in the male, basically about lubrication, not a whole lot else. The clitoris, even though it's analogous or homologous to the penis, and it has a hood like a prepuce or foreskin, it has an enlarged glans position, slightly so, etc. And so we look, and then look at this, and then look at this. So now you can see glandular tissue, okay? You can see, but look at the if you go back and if you could do a side by side with the male, in my eyes, and I'm not making a judgmental discussion, you can see how transitions that are become, I hate to use the term, more common would be a better term today. Again, whatever your feelings are about that. I'm old. Okay. I don't want to. I don't want to say anything that's overly controversial, but it's the funny thing about it, as you get older. I remember what my folks were like. My folks got more enlightened as the years went on, rather than less enlightened. I like to think. Okay, but when we were kids back in the '50s, right after World War II, it was like everybody. It was a totally different world out there. This is the odd nugget about the breast, where we have it here. Mammary glands, obviously present in both, but effectively, with rare exceptions, only functional. You could induce, a lactation phenomena, I suspect, in a male, and who knows if they're going to do that or not. But I don't know how effective it would be. And again, milk production for the newborn. It's basically a modified sweat gland. I'm like most people think it's an apocrine gland. A lot of authors disagree that those exist. I feel that it's really what milk is. It's a colloid. It's got protein. It's got fat. I think it's very consistent. The area surrounding the nipple, however you pronounce it, areola or areola, okay, are there suspensory ligaments. They overlie on a bigger part of the underlying muscle, of course, is the pectoralis major. And for people who have reconstructive or augmentation or de-aug, whatever the reverse is, breast reduction surgery, yeah, a lot of it involves placement vis-a-vis the muscle that's there. My daughter has had that augmentation done. She lost a great deal of weight. And then it's like she changed because the breast is mostly fatty tissue. When she was bigger, there was more there. Then when she became a runner and a fitness model, there were less there. And she decided she liked the way she looked better changing it. And she had the resources to do it. Good for her. So, as you can probably guess from our limited experience together, I've had a lot of interesting experiences with regard to my family. It'll happen to all of us. It does. There are very few that have. See, if I said to you, Ozzy and Harry, look at me and go, what the hell are you talking about? Back in the 50s, they had the family shows where, where like mom and pop and the kids, and the big storyline would be somebody stole somebody's bike and how they responded to it rather than life crises. So most lives are not bereft of life crises. Okay. So, and there's a variety of ducts and sinuses. And what happens, the glandular structures increase during pregnancy and certainly postpartum in anticipation of lactation. But breast size in its elemency is usually due to fatty deposition. It's not necessarily consistent. I don't know how else to describe it to you. Let me show you this cutaway. The big deal again is the axillary, is the lymphatic drainage points toward the axilla. And unfortunately, that's where cancer cells go. That's why it's so important. And it almost inevitably, if they're doing a lumpectomy, they're going to do a lymph node dissection of the axilla because that's where it's going to spread. And it does so with an alarming amount of frequency. Most common malignancy, second most common cause of death in women, maybe smoking still number one, lung cancer. 13%, that's horrible. 1 out of 7, 1 out of 7.5. Epithelial cells when the duct's highly metastatic. Prostate cancer is as well. Okay, they move along quite a bit. The risk factors, which may or may not be considered. There's another slide that tells you some folks don't have that. Early onset or late menopause, no pregnancies or pregnancy late in life. That picture I showed you. Our new granddaughter. I mean, there's IVF. They're both roughly age 38. I think they both graduated from Penn State in 2005. I mean, I'm trying for a while, but it's just the way it worked. So whether or not that's impactful or not, she is trying to breastfeed. I don't know what the family history with her name's Carly. Okay. A large amount of women do not have the risk factors. Then you get the breast cancer genes. I'm sure you've been schooled on that, correct? Guys, right? Yes, no? Yeah. I would think so. I'll give you the story. Maybe I gave it to you. My first cousin, I haven't spoken to in a number of years. Not intentionally, just as you get older, everybody has their own lives. His wife, they had 5 children. And then when they got married, her mom had died, her mom's sister had died of breast cancer. She apparently developed it sometime after having 5 children. Then at that point, it was, she's probably 5 to 10 years younger than I am. So a woman in her 60s at least. Now, they discovered both of those genes. She elected to have a double mastectomy. Then she elected to have the reconstruction. And while one went well, the other one was fraught with problems. The last time I saw her was at my mom's funeral, which which is a good 12 years ago, and she was doing great. But you know, there's a tremendous amount of problems that are associated with these things because that's multiple procedures, and it really is. It's just got to be very, very difficult. That's there. I don't know how if the guidelines have changed. My nugget to all of you is just be on top of all of these things, please. Whatever, you know, most of these are non-invasive and for your benefit. I realize the mammography is an exposure to x-rays, but I really, because we understand it a lot more, and it's the oldest truism in the world, early detection generally bodes well for treatment, whatever it is, and that's that ostrich syndrome. I mean, you could be talking to an idiot who smoked for 40 years. Okay? So, you know, and until it really got significantly bad with bleeding and things like that, that I finally did something about it. So you're better off early on. Maybe I've saved myself a lot of the problems I've had subsequent to that. But that's as it goes. And the treatment and all that stuff and what they're doing, etc. Almost done. Physiology, not doing that. Big difference on oocyte production. So you're born, all of you born in late prophase 1 in what are called primary oocytes. You have, depending on who you read, 400,000 between both ovaries. So it begins, and then once you start to ovulate on a regular basis, that one, for whatever reason, is selected. Secondary oocytes in what's called metaphase 2, and that's where one has developed and has started to move on from prophase 1 into metaphase 2. Only does it complete meiosis at the time of fertilization. So, I mean, it's interesting in that regard. So the presumption for a long time has been that was the lifetime supply. There's a little bit of variation now. So how the selection occurs of that, the follicle itself encloses, is the enclosure for the egg itself. It has a variety of cells that are there with single or multiple layers. Okay, so there's not a whole lot to say, but the follicle is critical because that which survives after ovulation and forms the corpus luteum. So without going through all of these, because I don't think we need to, okay? And so what eventually happens, whatever follicle is selected and the egg that's in it begins to develop. And it goes through phases from primary, secondary to tertiary. And when we see, and you'll see the illustrations, when it's tertiary, we start to see a fluid-filled cavity. Okay, that's what's going to basically induce the rupture of the outer wall of the ovary to allow ovulation to proceed. Okay? And so before ovulation, that primary oocyte, once it reaches this stage, inside that follicle with the antrum and the fluid, okay, that's the one that resumes and eventually makes its way from prophase 1 to metaphase 2, and that's what it is at the time of ovulation. So we understand genetically, and here you can see it. Here you can see the vesicular or antral. In the old days, they used to call it Graafian. It was a proper name, capital GRAAF, something like that. And now we're using this name because it has that antrum, that fluid. That creates enough push on the ovary to allow for the expulsion. So here's the egg, still encapsulated to some degree with tissue. And here's the follicle that's left that very, very shortly turns this yellowish color, and that becomes the corpus luteum, which means yellow body. And that takes over production of mostly progesterone, some estrogen, until such time as either implantation occurs or does not. If implantation occurs, it keeps doing it, okay, until the placenta develops. If it doesn't, it basically atrophies, shrinks, becomes non-functional, and that's the nugget that into the absence of the progesterone is what induces those arteries to kink, and the onset of menstruation, we start the pattern over again normally. And the difference between the male, we get 4. If one starts, we get 4. And in the female, because of these things called polar bodies, you get a secondary oocyte and you get a polar body that is effectively discarded. And the same thing once it completes after ovulation, same deal. So only a small, yeah. It's only a tiny amount if you want to think of how many years, however you want to do the math, 30, 35, 40 years of ovulation. Theoretically, it's maybe 500 out of some 450,000 eggs. Okay. 99.9% are never brought in to ovulation. And so there's a limited number that are selected. Okay, if that becomes the dominant follicle. In vitro fertilization, a series of chemicals are used to increase the number of follicles that are selected with the goal of maybe harvesting 20. This is what my daughter went through on, I don't know, half dozen at least occasions. I'm sure I told you that already. So, and there's a lot to it. So whether in vitro, all those chemicals, there's a tremendous onslaught. I told you about my daughter-in-law having the daughter-in-law of my son in the Navy with her 2 children that way, losing her gallbladder, having an extraordinarily difficult first pregnancy. She was eclamptic, pre-eclamptic and eclamptic. She was in big trouble. Big trouble. Almost lost her. And again, if they would ever separate, which is never going to happen, we'd keep her. Absolutely. We'd keep you. And the kids. Let my son go. He's all right. Just wait till you have a soon to be 41-year-old kid. You probably can't relate to that. All right, moving on. I'm almost done with the bad jokes. Don't start. Okay, major nugget here that I went through a little fast. Okay, the cytoplasm aspect. Remember, the male, the sperm just contributes genetic material. All of the cellular and eventual organs, mitochondria, all of those types of things, and that's when we talk about things like mitochondrial DNA. The mom contributes all of that. The male contribution is basically genetic. All the other parts are future cells. And that's why when we look at mitochondrial DNA, we can't get a full genetic picture or use that forensically to exclude or include, but it gives us an idea whether it was a family member or not. That's kind of the way that's utilized. And that's the difference and the error rates. And you can get an idea, okay, of the timing here. And I always find these tables that are kind of interesting. Less than 500 number of gametes per lifetime, eggs that are ovulated, men an extraordinarily high number because of all the sperm. And different error rates are associated with them. And we don't need to go into all of these per se with regard to this. So, and again, I do more of this with my advanced group. And depending on where you're going career-wise, like for instance, if some of you go into a field that does a lot of maternal child or gynecologic activity, you'll probably learn more about this just from doing it. So I'm not skipping it other than the fact that there's a lot of language here that you may or may not need. But there's and these are pretty good pictures that demonstrate the start, how it's finally selected. Now you can clearly see the antrum, and that pressure allows for that to be expelled, okay, from the ovary. So, I mean, and different responses. Estrogen is about development. And what's interesting when we get to it, the FSH is in fact the estrogen. LH, luteinizing hormone, big player, because that's the trigger to induce ovulation. called the luteal surge. Okay. So that's why I'm buzzing through these without going crazy. 2 cycles, ovarian, menstrual. The key is to put them together and to see the events. So ovarian, well, and there's certainly a couple of questions about this on the exam. The ovarian cycle has to do with egg development. Obviously, the menstrual cycle has to do with the uterine lining, the endometrial lining that's there. So these are consecutive phases, and they're separated by ovulation. The one that is consistent in timing is the luteal phase. Post-ovulation, it's about 14. Post-ovulation, it typically is around 14 days, as you can see. There is some subtle variances in the follicular phase. As you can see, most women, at least statistically, have those variations, as you can see. Post-ovulation, it's pretty well understood because we know how long that corpus luteum will function for. So ovulation is generally the piece where that separation occurs, and there's certain things that you can trigger with this. And maybe they have changed today. For us, when we were trying to have children, having difficulty, knowing that we would, because my first wife's polycystic ovary disease, was she would do a thing called basal body temperature. She'd take her temperature first thing in the morning, and you'd map it. It was with a thermometer back in the day. We didn't have digital thermometers. You had a more sophisticated typical thermometer, and you would be able, it would be like, so if it was 98.6, it would be 98.65 and 98.68. And you'd map that out, and when you saw the discernible spike, that meant you're ovulating. So you wanted to try, then you tried that. Perhaps they still do that, don't know. Okay. So the one dominant follicle we talked about. So in that earlier follicular phase, we start to see the drop. So follicle stimulating hormone is what happens, is the governor in the follicular phase. The levels drop in about the middle of that phase because a dominant follicle has been selected. And the other ones that have potential will, what they call atresia, they'll basically die off or atrophy. Okay. That's there. So when we finally get to the completion of development, the German term Mittelschmerz, pain sometimes felt at the time of ovulation, in sort of mid-cycle pain, 1 to 2% of ovulations release more than one, so it's a small number that has some hereditary governance. Okay, result in twins. So you can have identical twins or fraternal twins. Fraternal twins, non-identical means 2 separate eggs. Identical twin, 1 oocyte that separates initially into 2 daughter cells. Okay, and yeah, there's some oddball release times as well. Interesting for those of you who might undergo. That's part of the thing when I'm telling you about IVF with inducing multiple eggs. If somebody is predisposed hereditarily to multiple births, those kinds of things tend to increase them. Some years ago, there was, I think all the children, we called the octomom. She had like 8 kids at once, who are now probably adult size or close to it, I would guess. That's what happened. So when my first wife and I were contemplating IVF, my dad's brother and sister were fraternal twins. His grandfather, triplets. So they were telling us, watch out. Could be a bunch. Okay. Unfortunately, the end product was none, but that's okay too. What are you going to do? After ovulation, the luteal phase, okay, so the ruptured follicle collapses, the antrum fills with clotted blood, but the granulosal cells that are sort of the external portion of the follicle become that corpus luteum, and that takes over. Basically progesterone with some estrogen. And again, if we don't have pregnancy, that's not fertilization. Pregnancy implies implantation. 10 days, that's why we have that. Then it goes that there's the endometrium then begins to erode when that stops working. And now in the case of pregnancy, the corpus luteum basically sustains that pregnancy, until the placenta takes over around 3 months, end of the first trimester. Finally, this is the part, again, I do this in the advanced, and because they need it for medical college admission testing or MCATs, okay? It's prepubescent women, tiny amounts of estrogen are secreted. And now at puberty, and this is the hidden nugget, leptin is something that's produced by fat cells. Okay? That's why women body fat should be between 5 and 15% in order for them to have normal reproductive health. It's a pretty acceptable number. Either by accident or intent, people who crash diet sometimes have a great deal of problem because they have inadequate fat levels that are there. So when they used to do those tests and you could figure them out, and BMRs and you know, the BMI rather, those basically what percentage of body fat is. People who had below 5% were problems. It could intentionally delay the onset of puberty because if there's not enough leptin, what happens is the leptin levels are adequate, meaning there is enough leptin or fat. The hypothalamus all of a sudden becomes less estrogen sensitive. And then the GnRH, why it happens there, I don't have an answer. And you eventually develop the adult pattern. Case in point, I shared this with all the classes. I reiterated to one of my colleagues the other day. My daughter was a pretty good figure skater. At the end of her figure skating career is before RMU. She skated here at the Island Rink before RMU owned it. A gal she skated with for a good 5 years, had over at my house when my kids were little, I can't even tell you how many times, there's 5 levels of accomplished figure skating. When you watch the Olympics, they're seniors. Junior Olympics, they're juniors. Girls and boys who are trying to get there, the next phase is novices. Underneath that, where they still have what they call the junior nationals, are intermediate and juvenile, then intermediate, then novice, junior, and senior. My daughter made it all the way up into intermediate, senior in some areas. Long story short, the girl she skated with won nationally about 20 years ago from here, from Mars, PA. Won juvenile and intermediate. She landed a double axel when she was about 11. She was super tiny. So I took her, and I did not know her parents were doing this intentionally. Slept overnight, took my kids to the community pool. 2 boys, she and my daughter, 4 of them. I said, guys, have a great time. I'm going to go get fries and drinks. What do you want? Brought them back. She goes, I said, have some. She goes, my mom and dad would kill me if I had a French fry. What does that tell you? It's an 11-year-old girl, 12-year-old girl. Are you effing kidding me? Got to watch out for parents they think every little kid who has a modicum of ability is going to be the next great skater, or a great gymnast, or a great whatever. They're going to be Simone Biles. They're going to be, and she does all the commentary now, and she won when she was 15. Tara Lipinski. And my daughter is about the same age. She skated out of University of Delaware. I mean, we competed at University of Delaware. So I've been through these wars. Moving on. So that I make that point to all the classes. Understand, it's more important to be healthy in life. Nothing ever came of her skating career. Unfortunately, I don't wish bad on her. I wish bad on parents who do that. Okay? All of these have to be appropriate. We're not going through all those. And basically, when you're produced, these are inhibited from cells of that granular layer that make up the corpus luteum. They inhibit negative feedback on follicle-stimulating luteinizing hormone. So if someone is pregnant, they're producing chemicals, estrogen, progesterone, and inhibin that stop it. That was the basis of the early development of birth control pills, which haven't been around as long as you think. Okay, they were a product of the 60s. That was one of the great medical revolutions, the ability to control when someone wanted to be pregnant. Not without problems then, because they did cause a lot of problems. And maybe they still do. I don't know. Okay, so that's not something pharmacologically I'm able to tell you about how they change, but there have been a lot of changes. And if you don't think that that changed the world that we live in, you're wrong. Everything changed in regard to that. So estrogen levels continue to rise. When they reach a critically high value, that's during that first phase, follicular phase, positive feedback occurs on the brain and the anterior pituitary, and then you get a surge of luteinizing hormone. That's ovulation, the expulsion of the egg, and the development of the corpus luteum. And you'll see this without me talking about all of the types of things. They go through all different enzymes and blood flow to the protruding wall, et cetera, et cetera. And at that point, estrogen levels decline. What's left of the follicle turns into this, mostly progesterone, some estrogen. I'll show you the chart. And that maintains that functionality until implantation, if that's the event that occurs. So if no fertilization, again, a very sharp decrease, okay, in turn ends the blockage of these, the cycle starts all over. So the oocyte is actually activated about a year prior to ovulation, but it's that 14-day period. So the selection process is interesting. So we marry that to the menstrual cycle. During menstruation, first phase, days 6 to 14, pre-ovulatory, preparation of the start of the functionalis, not maturity of it. After ovulation, it matures aggressively in anticipation of implantation. So obviously menstrual phase, the functionalis detaches. Proliferation phase, generation of the new functionalis, not ready yet. All about estrogen, synthesizes receptors for progesterone, thins out the sticky cervical mucus in anticipation of sperm passage, ends relatively abruptly at day 14. This is the most consistent phase. This is all about preparing the endometrium. It probably takes 7 to 10 days optimally. Okay, glands enlarge, the mucosa begins to secrete materials. Now a mucus plug reforms very famously and will deteriorate again in the absence of implantation. So the luteum degenerates, spiral arteries, in the absence of it, endometrial cells die. Then with that relaxation, that rush of blood that I was talking about, we start the whole cycle over again. So these are the charts to put together as we get close to the very end. Luteal surge, you can see mid-cycle on or about day 14 typically, okay, with enough variation. We look at what's going on cellularly. Dominant follicle eventually begins to develop, ovulates with the surge, corpus luteum, and then this forms what's called the corpus albicans. It turns kind of white and it's basically atrophies or shrinks. Estrogen rising predominates, progesterone does not. Post-ovulation, progesterone dominates, estrogen lessens. This is what happens after menstruation, those first 4 or 5 days, then the development, and finally the maturation, if you will, the start of, the growth of, and then the maturation with all those glands. Put them all together, that's the chart to understand this. Luteal surge, ovulation, estrogen, a little spike that induces that luteal surge, and then you can see the change and now the development here. that goes on. And then you can see as the corpus luteum, in the absence of implantation, now that whole thing, we'll start the whole process over again. So you can go through that. So again, the little body fat, all of those problems playing a role in puberty, lack of leptin can shut down, again, intentionally. There's a lot of problems that are associated. So even young, healthy women can, and this is part of the problem, can reverse if a woman increases body fat. We can see a lot of problems postmenopausally, even in young people who are trying to induce almost like a menopausal-like, if you want to call it that, situation. So what do estrogens do, or the absence thereof? The opposite. Egg and follicle growth, anabolic effect on the reproductive tract, growth spurts involved, secondary sexual characteristics, etc. Maintains low total cholesterol, high HDLs, that's desirable. The absence thereof is undesirable. Calcium uptake. Progesterone works together with it. Uterine motility, breast for lactation, etc. So that's, and then we have the sexual response, which is very similar to the male, and the changes that occur associated with it. Again, the distinction between, in the male, it's always associated with ejaculation. In the female, it can happen, as we know, more frequently without that sort of reset period that's common with the male. They don't have the refractory period. It's not necessary for conception. Again, there's a variety of things. We think that androgen from the adrenal cortex plays a role. Most people agree with that. And then everything else on this is STDs, which we do again. But a couple of things that are just a few little nuggets as I conclude. Again, condoms have been they've been around forever, but relatively new. Post-HIV, a lot more people started to use them. That was the distinction. We had an immense amount. That's scary. If you want to make an argument for the most highly developed country in the world, having the highest rate of STDs, what does that tell you? What does it tell me? Absence of education, provincial habits. I don't know what it's like in your homes. I know it was like as I was a kid growing up. This is why I was sharing that with another class, is we didn't talk about that stuff. Oh, you didn't talk about stuff like this. Oh, we don't talk about that at the dinner table. You didn't talk about sexual problems or things like that. We didn't see pregnant girls in high school. They all went to live with their aunts. Okay? It was all of that. That's the better part of 60 years ago. So the provincial attitude meant, and if you went to Europe, okay, it would be commonly discussed. Okay, people who came from other countries would say, "Why don't you guys talk about this?" We tried to be more proactive. You see how well it worked with my daughter. She only had her baby at 15 and a half. Just saying. So maybe we were unsuccessful. I'm sorry. Okay. Number one, bacterial STD now used to be gonorrhea. It's chlamydia. Big problem. Nearly half, quarter to half today of PID cases, because the biggest single problem is women are often asymptomatic until it is too late. Why there's less gonorrhea? Gonorrhea is more symptomatic. We go over this again. So a very limited amount. That number is wrong, by the way. The male urethra is much more symptomatic with particularly these drainage disorders. It's painful. There's all sorts of things. Why we use antibiotics now mandatorily in the eye. We used to do something called silver nitrate. So you have to use antibiotics at the time of birth. All states. So it's just an eye drop. It's fine. Not a problem. Trichomonas vaginalis is a parasitic infection. We call it a eukaryotic cell, similar to our cells. It is, in my pecking order of most common, we have HPV, trichomonas, herpes. So the good news is easy to treat. The bad news is easy to get reinfected. Years ago, it was only gonorrhea, and we classified everything as being either gonorrheal or non-gonorrheal. That's the only we didn't know about. We didn't have the availability of diagnosing chlamydia or trichomonas nearly as well as we do today. So that's what they were called, and we didn't really understand the treatment quite as much. So gonorrhea, big problem. We'll go over that when we do micro. We see less syphilis, though it's making a comeback. If you did not know, in nearly every state in the union, up until, I'm going to say, roughly 1985, arbitrarily, they required a test, a blood test, before you got married. When I got first married in 1978, the blood test wasn't to prevent you from being married. It was to identify whether you had syphilis so the health people could trace it epidemiologically. 2 states did not, West Virginia and Las Vegas. That's where people went to elope to get quote unquote quickie marriages. Okay? Pennsylvania was not one. I don't know when Pennsylvania stopped. I'm guessing around 85 or so, more or less. And so now, we got married in 2013 in San Diego, destination wedding, not ours. My son was getting married 2 days later, but we had a special on Wednesday afternoons. They did. Don't look at me like that. Why don't we get married? Yeah, why not? You want an upstage, traditional marriage with our second marriage. Hey, if everybody's getting married, you've got to get married a couple of times. I'm joking. So I'm not going to go into it, or HPV, because we're going to cover it again, or herpes, we're going to cover it again. And thank you very much. Have a wonderful time until I get that stuff to you on Sunday sometime, as yet not to be specified.
Sunday morning.
Yeah, everybody's.
Is it already done?
What?
Is it done? Like the figure 7, is it done?
Yes.
So why don't you just send it?
Give me a break.
Because what if you forget?
Surely somebody will remind me.
I think you should send it out.
If Grace doesn't remind me, I'll be shocked. Won't you?